So I'm George Isham, the co-chair of the Roundtable with David Kindig, and we're not quite done yet. So we've had an incredibly vigorous, stimulating conversation today. I don't know if you felt it. We've also had comments about momentum in the room, quite spontaneously, at least I've heard both in the private exchanges and in some of the comments made to the group. So something exciting is going on here. We have the responsibility, however, to put our reactions and our analysis in a form that will reach beyond this room. And one of the things that the Institute of Medicine does is that we'll circulate the video of this conversation, or we'll make it available on the web. And we have the opportunity to produce written products, commentaries. I think Rajiv, he must have left already. His last set of comments might be one such commentary. I'd like you to think of what other kinds of issues have come up during the day today that could bear some written expression and suggest those here in a few minutes when I ask them for you. And then thirdly, we'll produce a written summary of this discussion according to IOM rules. But according to IOM rules, if it's not in the discussion, it doesn't get in the summary. So I'd like you to step back a little bit from the conversation we've just had and think about what you've heard over the day and what the implications might be. And I'm going to go in a second here and ask you for that. I'm going to give some emphasis to the responsibility that the Roundtable members themselves have to do so, but I'm not going to limit the conversation to those folks because we've got a lot of bright people in the room. So let me start. I thought this last point that Matt just made was my first point that I was going to make in summary, which is the larger purpose of measurement from this conversation's perspective. If we from health want to achieve broader impact on health as well as health care, we need to think about the framing of this. Is health the input, and does that foster engagement? Does it help with the rationale for why we think health is important? I've heard some examples over the course of the day that actually making the point in terms of economic development or education might be a better way to frame it in order to get to those factors that actually produce what we're maybe interested in coming into the conversation, which is health itself. And so we need to be a little smart about that. I, in some conversations, and I've had this thought before I came into this room today, have used the Greeks sort of to think about it a little bit in terms of asking the question of whether a focus on health is a bit narcissistic. From the standpoint of we're only looking at ourselves, since many of us come into that conversation, and I know not all of us in the room come into that conversation from healthcare or health or public health, but many of us do. And if we're not thinking beyond that, are we being a little bit like that Greek story? So that's the first point. The second is I've had some thoughts about system as I've listened over the course of the day. And I think starting right from Steve Teutsch's excellent summary this morning, thinking about the components of a system and thinking about that relationship between purpose, between measurement, between the data resources and infrastructure that's needed to capture this, and the results and how they will form a loop, a feedback loop, hopefully, an effective feedback loop with the doers that are actually going to achieve it. We need to think about that. You can't, if you take metrics alone and then you talk about that, if you take purposes or larger purposes alone, talk about that, and if you take doers and actions, or if you think about it as just one level kind of system, say a community, and think about a community, you can't stop there. You got to think about the individuals in the community. And you need to think about the states and the federal government, because the resources are allocated differently across those levels, and they actually interact with one another. And I don't think that's been really adequately described in terms of thinking about the measurement system or lack of system as it currently exists. So one thing I've come out of the conversation today about, stimulated by that, is that maybe there's more work that we need to do in terms of thinking about how our fragmented, multi-level system with multiple stakeholders which are required to get to our end point of improved health, how that knits together and what the dynamics of that are, and think of it as more of a system. So that's probably the second big point. And then this, David, you talked about central versus local. Very fundamental sort of conundrum that comes out of the conversation today. So on the one hand, data and systems that collect them are hard to invent locally and fund locally. And yet, we've heard today several times that the stuff needs to be really relevant to the people in a particular community. They need to be engaged in developing and so forth. So for borrowing from industry is what we need as a mass customization kind of system. Do we need some sort of mass customization is where there are standards in order to create things, and then when you get to the point of delivery, you give the customer exactly what they need, and they tailor it to the next one. But the system and assets and resources are built from, in terms of that ability to take advantage of mass production, and that's where the term comes from. I'm probably explaining this terribly wrong, but that's how I remember it. But what's the public health? What's the public health perspective on that? And what's the interaction between state, federal, and local government, between asset allocation and this challenge of being able to tailor something very specifically? Or this conversation that Steve and I almost got into an argument at during one of the sessions here around parsimony. So does parsimony mean only 6 measures and that's all you get for the country? Or does it mean that any particular person can only deal with 6, but it has to be drawn from a set of 10,000 or 600 in order to be able to really get to the fact that all these different perspectives need to engage, and they need to engage from a specific perspective and so forth in order to get the results you want. So anyway, those are a couple larger thoughts about some of the implication of what I've heard today. I'm turning to you now. I've got all of this, and I'm unable to really digest it. I need your help. What have you heard in that sort of larger, reflective kind of mode that you think ought to be in this workshop summary that's important? Comments? Yes, Meg? You need to have the microphone so that people in the web can hear you and identify yourself.
Meg Guerin-Calvert for Center of Healthcare Economics and Policy. On your very last point, something that was discussed at one of the tables I was at really goes, I think, toward it, this idea that if we can identify the locally relevant data that most communities will need, even though not all of them may want it, and we could identify, are there gaps in that data? One of the things that came up 2 or 3 times was the idea that some of the BARFIS data, which is of very high quality, really doesn't go below the larger metro areas in terms of yielding robust and reliable data. So not every community may want to use it, but one of the areas perhaps to explore, are there some specific metrics that are in the set of 600 or 500 or 400 that are going to be potentially desired by most that really are not available yet, that funding, resources, research could go into to developing.
Good point. Other points? Jose. Jose knows that if he doesn't raise his hand, that eventually I'll start calling on Roundtable members. Jose, please.
Presenting. Jose Montero, VP of Population Health and Healthcare Systems Integration at the Cheshire Medical Center, Dartmouth Hitchcock in New Hampshire. Here as a member, past president of ASTO, Public Health Directors of the U.S. So first of all, thank you very much to the organizers. As always, a great session. But as I was telling George earlier, this last part, the cafe, is an incredible event, listening for us as members of the roundtable to everybody else, the different ideas and how we connect things and how we don't, actually really ties into the discussion that we are having. So do we have a group of people coming with measures and we're going to do a top-down approach across the country because we decided as experts that those are the right measures? And the EPI in me says, yes, that's the right way to do it. The politician in me says no. You need to ask people what they feel, what they think, and translate the measure to the local values and needs. That doesn't mean that you're going to change the measure. That doesn't mean that you're going to completely redesign it, but you're going to transform it in this mass customization that you said to get it to a level where the communities can use that data. We saw this morning 3, 4 different approaches of looking at those measures. So how more down the road do we need to go to identify more and more measures before starting to get some data collection on those and move them to action soon so we can start building that change that needs to happen with those measures? When we sit together, no offense here, as academicians, we want the system to be perfect so we can perfectly measure. We will never affect change if we wait for that. So can we, based on these discussions, have some sets of advice to how to modify or lead the process and who can do that? As a former health official, certainly I see the role of the new health departments as the forefront of the health side of the house, connecting with all of the other sectors. At a previous meeting, we were talking about how this health and health policies was interpreted as health imperialism by others. So the concept of well-being is better because then we can all work on that. But we need to acknowledge that there are many other tables out there. It's not that we're bringing other people to the health table. It's that we're building a bigger table where we talk about this with the other sectors, and we need to do that soon. So from the discussions today, this call to action, make the data and the measures actionable soon by engaging the community so they are empowered to take them as their measures and move them on, is something that we really need to get to fairly soon. So this discussion has been great because it has highlighted all of those topics. The task now is to make it happen. And that's the beauty of this discussion, that we have many of those players at the table.
Thank you, Jose. Okay, please.
Thanks. My name is Julia Kaplan. I'm with the Public Health Institute, and I lead California's Health and All Policies Task Force. And actually, the comment just before mine is you brought up some similar thoughts to what I want to share. I think a lot about the concept of a culture of health and this idea of making health really a shared value. And in my work, I do this with state agencies, in California and Sacramento. One of the big questions that comes up for us that I'd love to see an opportunity to explore more is around whose job is it to gather the data, who needs to use it, really thinking cross-sectorally about this and developing cross-sectoral systems for metrics and indicators. And an example of how I see this come up in my work is I'm constantly hearing from various stakeholders the question of how do kids get to school? How many are walking, how many are biking? And it turns out that we do not have a system for tracking that statewide. The schools that do track it, each track it differently. Not all schools track it. There's no way to aggregate it at the state level. The Department of Education wants to know. The Department of Public Health wants to know, of course. Transportation wants to know. Our land use planners want to know. Our governor wants to know because of the implications for greenhouse gas emissions and climate change. So what we're doing right now is forming a multi-agency working group to look at this question and start to figure out who holds the data. If nobody holds the data, how can we get it? How can we develop systems so that that data is useful in all of these different sectors that have different systems for their metrics and for information? And I think it just raises these much bigger questions in the long run as we move into this really multi-sectoral world of how we finance this kind of work, how we lead it, and really the work of building the relationships to be able to make this a reality.
Terrific. Thank you for that point.
Hi, Jim Nickman from the New York State Health Foundation. Just a few points, and I really appreciated the points just made. They were great. One is I was really pleased to hear from RWJF. I thought it was a great presentation, and it sounded like a really solid approach, and I think they could be a real asset and be nice to keep pushing on that. Second, it impresses me also that we need collaboration on metrics, and that came up at the various tables I was at and around the discussions. We have to figure out how to make the metrics affordable and common. I hadn't thought about the common point, but I think that is useful. We need a affordable health interview survey that could be done at the community level so that we can find out from people what's going on, and we need sensors and other approaches to more efficiently measure physical activity, purchases of healthy food, and all those things. I think that's an important priority that we need to get to. And I think choosing which outcomes are important, can be community-driven, but an approach to measuring them, like there should be a menu of things that you could measure in an affordable way. And then finally, the thing I struggle with all day is, because I like scale, is should we be pushing momentum now, or are we still in a learning phase that should be metrics driven and and sort of making sure we know what we're doing before we really push hard? Because all this will take a lot of energy at the community level, and if we do it once in 10,000 communities and it's not the right thing, are we going to be able to do it a second time in 10,000 communities? So I sort of go back and forth on that momentum issue. But I also think that as a funder, we're funding 9 communities in New York State. A lot of my other colleagues at conversion foundations are funding places. It's really important to learn from one another and that we have a common way of doing that.
Who have I got? Right over there.
I wanted to say that I'm not going to repeat things we've stated repeatedly and so beautifully by others. But one thing I felt that hasn't been said that maybe should be added to the record is that our ideas of what metrics are available, I think, are stilted by the ways we're accustomed to collecting data. So this morning there was a very interesting dialogue where somebody, I can't remember who it was, commented about the latency problem with data, and that was followed by a discussion of Twitter. And clearly social media provides one alternative to our traditional method of doing surveys and so forth. But there are so many others, I think the previous comment got to this, that I think we need to modernize our thinking about the menu of data sources available to us. 2 examples I wanted to mention that came up this week in my life that got me thinking about this. One was at our university, you can, and I'm sure you have similar things in your cities, use an app to know where the shuttle buses are and how many minutes away they are and what corner they're at. So you don't need to. That technology exists in many cities. So the idea that we need to do household surveys to ask people to get a sense of their access to public transportation is maybe not the most modern way of thinking about this. Another example that came up at a House briefing I was at earlier this week, so I think it's public enough for me to share my colleague's great idea. He pointed out that most ambulances sit outside the ER of hospitals when they're idle or at the fire station. And he said most 911 centers know exactly where every one of those units are. Why not position those in locations in where the highest number of trauma cases are, but also where the greatest medical needs are, because not only would that reduce transport times, but also allow them to actually stabilize people without even needing to go to the hospital. That kind of creative thinking is building on the fact that we have data that tells us where all those things are. So you don't need a survey to tell you what streets have high traffic activity because you've got Google Maps now that tells you where those things are. Those types of data sets, I think, could really liberate us to pull metrics that we think are important to our goals rather than being constrained by the traditional ways we've collected data in the past.
Excellent point. And now, yes, ma'am.
Hello, I'm Veronica Shepard with the Department of Public Health. I'd like to suggest, as you move forward, to think about the people who are not at your tables, particularly when I read a lot of data or come to these kind of events and see all the disparities concerning African Americans, I always want to invite people to learn to understand the history of our disparities. And at the Department of Public Health, in our particular division, we have an acronym called REACH, which stands for, wow, I went blank. Results, equity, accountability, and cultural humility. And a lot of times I'm learning, and I still continue to learn, we don't talk about what we do wrong. We talk about a lot about what we do right. But when I always look at the disparities of African Americans, Latinos, particularly health related, there's something very wrong when we look at this kind of data, especially over a continuum of years where we're collecting data about it and there's no change. I really would like to suggest, and I heard Rajeet talk to this about building partnerships and getting stakeholders that are doing a lot of very hard work, creating their own measurements to help shift how people live healthy and well. They need to be in these conversations that you're having as you're creating shifts and measurements. But what's most important that I find with my particular community is when we come authentic, when we're humble, when we respect the culture and let the culture talk, whatever that is, we can learn so much on how to help people live better. That's my recommendation.
That's a good one. Thank you. I would also add to the fact that I think in this, and it may relate to your point, but I think this conversation being held in Oakland with so many people from the Bay Area here has given another character to the conversation we've had than we usually have. And then I'll echo Jose's point about the fact that the dialogue portion of this meeting has also given us a much richer input. But I suspect we can do much more along the lines you're suggesting as well. George Flores?
Yeah, being in the Bay Area, we have an advantage of being proximate to the tech industry, Silicon Valley, and actually, I'd like to call out if there's anybody in this room, or how many people are in this room, from tech, because I know we have a tremendous number of innovators here, and they have conferences about health technology and health data technology. What Steve Wolf was pointing out about apps, and they've had codathons and hackathons to come up with new ways of looking at collecting data. I mean, you've got smartwatches and Fitbits and things that are collecting data that could be connected electronically and give us a wealth of information in new ways that could make us much more aware in real time about what's going on with people's health. So are there folks here that could speak to this, that maybe what
From Silicon
the
Valley?
tech industry is doing?
Tech? They left. So I will say, I was here in the Bay Area last week in Oakland to interact with the folks at Stanford around the design of health primary care 2.0 as they kind of look at that. And one of the things that I raised was this issue around the relevance of neighborhood to where their health centers were in their design process. But you know, in Minnesota, which is not tech, we have an app that tells you what the wait times are at the urgent care centers that you can look at. You know, there are a lot of ways to use that kind of information and apply it to so many different things. So that's healthcare, but you know, access doesn't need to be that way. We also in Minnesota are a little more advanced than at least the examples I heard last week around how you look at primary care as a process as opposed to as a place and a person, and how you can cut the cost as well as improving the result. And again, a healthcare example. But I think there's a broader community, and I know from Kaiser, just thinking about Kaiser, they're thinking about these things. I think there's a broader opportunity in terms of technology and how it's being used in some of those venues, and then thinking about how it can be used in some of these other health conversations that we have. So George, I'm saying this by way of agreeing with you, and I think we really need to really try to see if we can energize some of that input. And you were going to make a comment. Go ahead.
Yeah. So I get to live Hi, Leah Vaughn, and I'm a physician epidemiologist, but I've also co-founded a startup and exited and lived part of my life in tech. And I think I would endorse the notion that there's great promise and potential in the current ecosystem. But I would also caution that there's an extraordinary amount of hype and not too much substance between a lot of what is funded to an absolutely stratospheric level by any standards of public health. And so I would say part of that's engagement, being very clear about numbers, and that public health knows a lot, epidemiology knows a lot, statistics knows a lot, but being open to these other wonderful data sources that do give us more context and content about what drives health and communities.
Steve, do you want to make a comment? And then behind you.
So one of the things that came up in our conversation was, so what do communities do with these data? And some of the things that we've heard are sort of low-hanging fruit that we know what to do. But part of the problem is our evidence base about a lot of what moves the needle in social and environmental health is unbelievably poor, and we underinvest in that kind of research, and certainly the transdisciplinary research that will allow us to give these communities information about what to do, not with somewhat these things that can be fixed with efficiency measures, but how do you get kids to graduate at a higher rate? And how do you re-engineer our transportation systems? These are costly and complicated, and we don't really have all the studies and information that we need. And I reflect back on the UK, which has made a huge commitment to changes in social underpinnings of health, and they've had a hard time showing that it made a much difference. And I don't want to be sitting here 10, 15 years from now sort of saying, well, we sort of gave it a good shot. But where we've really acted on an insufficient base of knowledge. And I think we're going to have to struggle with when do we have enough information to actually help these communities move forward. And that's going to take a real investment in looking at how well the interventions that they do, or that we do, actually work in practice, because they're complicated.
So our next workshop is on research. Paula Lance is heading the planning committee. I'll bet if your comment is stimulated, I mean, if other people have that sense, do you have that sense about what Steve is saying is an issue? Can you think of some examples? Email them into the roundtable. Who should I have them email them into? pophealthrt@nas, and label them for Paula so that she can get those ideas for that planning committee. Because I suspect that the people in this room, if they spend 5 minutes writing down the first couple things off the top of their heads, and if we get enough of that kind of response, that could be useful to your planning committee. So that's a great point. Matthew, you're next. I want to.
That's right. That's right.
Matthew's next.
This is
I looked at him several times and went over him, so he's next.
no. It's a bit out of sequence now, but for the ideas that if it's not on the record, it's not part of it. You were asking questions earlier about the idea of the tech industry engagement, and I am not in tech industry, but I do work extensively with the kind of what is called the quantified self movement. And actually, the name says it all into why you guys need to engage as population health, because actually it's actually incredibly remarkable, all of the sensors and technology that are being generated, but they're incredibly focused only on individual health. And there has not really been a lot of thought about how to utilize these tools or the data coming off of them at a higher level. But there are notable exceptions. I think the one thing I would say for the IOM to think about is it's so important that community has almost unlimited potential in terms of developing tools. However, they need guidance to know what to make, I think, because, I mean, things can happen like the Apple research kit, overnight. And so I think it's going to be very difficult to guess the exact right tool to use or data. Tech moves too fast. Instead, I think it's best to try to, what do you want to do with the sensor? And then the tools will keep evolving very, very rapidly. So that I just wanted that on the record.
That tension between the individual and the first level of collective, the community,
Very difficult.
is an important tension that needs to be explored. And I think we've had a number of comments around that. Rajiv, you're next.
Perspective on tech, and I'm doing some work with a startup that does healthcare analytics. But I think that you have to understand tech. Its interest is not health. Its interest is in a replicable, scalable business model and a 10x and a 100x return. Healthcare is a $2 trillion beast, and there's opportunity there. So I think that's first and foremost about tech. And yet it has incredible smarts, capacity, skills. The best and the brightest are not going to Wall Street, they're going to tech, and therefore it can do a lot of things. Harnessing that for good, I think, is a challenge. On Steve's point, do we have enough information to act and be certain that we're going to move the needle? No. Do we? But we don't. We can't know until we do. I think the thing about healthcare is, oh, here's a new drug. Let's try it. Right? It gets tried. It gets tested. There's a business model for it. And I hate, I'll say it this provocatively. We don't have a business model for health. We have a business model for sickness. And I'll say it again. We don't have a business model for health. I mean, so we're going to have to, I think we're going to have to experiment and evaluate. And I think that's something, there's a lot of principles in tech and how tech operates and startups operate that really, in working principles that are really exciting that we should bring into the practice of health.
So harnessing tech for good and collective purpose. Huh? Okay. And then thinking about the business models. Martha?
So 3 different ideas. One is just to say again that I really am in agreement with this notion of being broader than cultures of health and talking in terms of things that are important. Just facetiously, we are constitutionally looking for life, liberty, and the pursuit of happiness. Life is certainly, life expectancy is a health measure. Pursuit of happiness, perhaps it should be the culture of happiness. That may not go over so well. But in any event, if we join forces with other sectors, some of the problems at the local levels where there is resource starvation might be attenuated because there would be lots of other players who would be interested in knowing that information. So again, I think the Roundtable needs to really begin to hear the messages we've been hearing over the last couple of years, to think about changing our terminology, maybe even changing our name, but that's for another day. To get to something that Jim Nickman talked about, should we be sort of implementing at all the different communities around the country these sort of processes of local configuration? It seems like that's a great sort of foundational demonstration to do, to look at a set of indicators that are largely viewed as being what we want to be looking at in lots of different sectors, and then ask many different communities to get through the processes that end up at those outcomes and see what everybody does, and then take that information and go to scale with that if it's ready, so it gets done in pieces. The third thing I want to say is that the ACA maybe has some opportunities embedded with it. It's going back in part to what Rajiv was talking about what can be accomplished in the medical care setting. There's a lot of money in the medical care setting. There are certainly in the not-profit sector the notion of community benefit. Interesting to think about community benefit as being a place for putting in some of the social determinant of health data collection things. That would certainly be a wonderful idea, I think, to promulgate. Similarly, in the area of community health needs assessment, which everybody's sort of required to do, and then they describe things and things fall flat, maybe one piece of that would be to actually go to people in the community and ask them what things they think should be measured, and sort of integrate that into a community health needs assessment.
Thank you. Very thoughtful. Mary Pittman. Well, you go first then.
Real quickly. So my name is Kelly Ward, and I'm here with the U.S. Green Building Council, and jumping off of Rajiv's comments about the lack of a business model, and then also yours, Steve, about measuring progress maybe at a point before we're too far down the road. One point that was discussed this morning in some presentations, and I don't want it to get lost, it didn't come up very much in the afternoon, was the need for these process metrics. It's something that we've identified. So I have a public health background working at the U.S. Green Building Council, trying to create tools for architects and developers to better consider the health outcomes of their work, and it becomes obvious really quickly that the traditional metrics used by population health folks and the healthcare industry are not appropriate in sort of built environment settings, and it might be easier to measure the actual process to have an idea of if we're going down the right path before waiting for that ultimate health outcome. So just to highlight that as a need for focus from population health experts such as yourselves is the creation of these process metrics.
Thank you, Kelly. Mary Pittman.
Sure, thank you. I just wanted to tell Martha that there is a World Happiness Report, and it came out, there was a survey on the state of global happiness. The first report was published in 2012, and then in 2015 there was just another one. I had a colleague who went to Bhutan to study the gross national happiness. So there is a lot that we can learn from other countries that frame these concepts very differently. We kind of laugh, but if we take a look at how metrics, indicators, and the framing of health is placed differently outside of our construct in the United States, I think there's a lot that we could learn and probably apply. We always go to the OECD data to show how poorly we're doing in terms of our health status and the cost of health. It might be good for us to flip that around and find out what are they doing well that we might be able to apply. And to Rajiv's comment, I totally agree that we don't have a good business model yet for health. And I had been sitting here doodling and trying to think what might be some components of a business model for health. And I thought, well, first of all, equity and some of the policy drivers around improving fairness and equity. We could there have been a lot of studies and a lot of conversation about what the cost of those inequities are. Quality, improving the quality of health in this country. Organization, how do we organize around health could be another part of the business model and take some of the costs out of the way we're chaotically addressing health. And then where we're making our investments, how do we begin to pull that together and say, if you totaled up where we're investing now in things that are causing disease, how could you take a portion of that and put it into health and tie it into an ROI that could be sustainable? So just, I think it's worthy of our spending some time trying to take a look at creating a business model.
So I'll confess to Martha that I've also had this thought about life, liberty, and happiness, and a number of us at HealthPartners have actually tried to circulate some literature on happiness to try to figure that out. So I think there's something in that thought. At least I'll add that much.
Field trip to Bhutan.
There you go. Field trip to Bhutan. Okay, right over here. How many more comments do I have? Could you raise your hands? We're down to the final minutes here.
I would say my colleague also said, how do we measure hopefulness? I think coming both from Brooklyn, we realized that hope kept us, even though we were coming from poor neighborhoods, how do you measure hopefulness instead of different from resiliency? Because it means you have to. But I would say, take off a colleague, I think where we would need help is developing performance measures. Our community isn't opposed to saying that breast cancer is a problem, but in developing the intervention, how do we know that it actually works in a way that is a better performance measure is where we haven't gotten into. I don't think community doesn't say healthy weight is not, but if we do an intervention that it actually had a result that we, for someone's help. And I don't think we've done a good job. So I think a roundtable drilling down more on the interventions we do into performance measures to achieve may be the next step that you may want to consider.
Thank you for that suggestion. Right over here.
Yeah, I just want to say that I feel like we're moving into Can you hear me? Oh, Abigail Crock, Contra Costa County. I feel like we're moving into the old adage of the man looking for his keys under a light post when he dropped it down the street. And a lot of the talk about population health metrics is centered on clinical, like, you know, the promise of the EMR, but the clinical population is not the general population. And the same thing when we talk about use of technology, Twitter or Fitbits, that's not representative, and it's not going to represent the population where we have the biggest disparity. So I would caution, as the idea of population health is moving into the clinical setting, that we're actually going to be moving away from the populations that need us most. And I want to concur with my colleague from San Francisco that where we need to be moving is being able to demonstrate change in communities, because I don't want to go and show life expectancy charts anymore. I want us to be able to say we're doing something about it.
Okay, right over here, and then I'm going to Tom, and then we're going to conclude, I think.
Judy Monroe from CDC. I just want to tell everyone I'm feeling really happy because I think today's workshop has been really good. I mean, starting out with, you know, metrics for purpose and action just really set the tone, and it's been great to be here in the Bay Area to hear all the great thinking, because that really has brought a real energy to this workshop, I think. I wanted to comment on the RWJ's culture of health, and I commend them for their 20 years, but I'm in an office that works with the tribes across the country, and the tribal leaders, our Native Americans, when they make decisions, think 7 generations ahead. What's the impact? So 20 years is 1 generation, that we've got a long ways to go, and I think we do need to, as we think about our metrics and our work, we need to think really long term. So I just wanted to point that out. I had a lot of comments about the app, so I just agree with everything that was said. I like the Zillow idea. We need more of that. And then just a few measures that I haven't, some metrics we might want to think about. I think public health needs marketing metrics to get this out. We should think about, and I had a conversation with Julie about relationship metrics, because relationships they really are the oil that makes things move smoothly. And then unintended consequences of our decisions. What are those metrics? And I was really taken by the map of Eastern Kentucky and the fact that the consequences today are based on policies that were made earlier. So I'll end there because I know we're short on time.
Thanks, Judy. And Tom, you've got approaching the last final word, maybe not exactly the last.
Okay, then I'll be brief. And so from the standpoint of, in the spirit of saying it, to put it on the record so that we can put it in the write-up, I'm going to say that, you know, we talk a lot about, you know, on this roundtable about population health, and population health is different than the way it's being sort of rolling out in the clinical setting, in the healthcare area. But the healthcare is where we put a lot of resources as a society. You know, we would, I think, probably all agree, disproportionate to its impact on population health. But that is where the money is. And I think that there's one thing that we haven't really talked, I don't think, enough about, and that is how do we infuse the health care model with a population health perspective. And as we look at the way that this idea of personalized medicine has been rolling out, it mostly comes out as, you know, kind of pharmaco reactivity, and, you know, but there's another piece of it that does have a population health component to it. That is that patients come into the system from a context, a community environment in which they're living, and there are pieces of data that come with them from a social determinants frame that have an impact on their ability to kind of respond to medical treatment. And we don't yet know enough about so if we were to infuse the electronic medical record with this data that we have, these metrics, and make that information available at the bedside, we don't yet know what then do we tell the clinician to do about that data. And I think that that's where we need to start thinking. How do we get that information about community context into the healthcare system, and how do we then educate the healthcare providers about what to do with that information? And it's an idea that I've been thinking about that's percolating a bit, and I think that we need to start thinking about that, because that is where the resources are, and I think that's where the rubber meets the road, and
thank you for that, Tom. I was actually going to end on a similar note that I hadn't, although it was mentioned a number of the frameworks that Steve Teutsch talked about. the cost and resources maybe didn't get a lot of emphasis as much as I think is important. I actually think it's a measure of health because of the toxic effect it has on the other determinants. You have to kind of turn it around. And then you really have to think about the allocation of resources across purpose and impact. And I'm not so sure we've done that as effectively. So I don't know if it's exactly the same point, but it's a similar point. I think one of the ones you're making. And we need to think about how to do that and how to emphasize how ultimately that action pathway and those interventions that lead to a more appropriate allocation of resources so we can create this better health in our community. I wish we could go longer. I wish we could. This has been an outstanding day. I think, first of all, I would say that of the speakers we had this morning, I can't imagine. I think we've set a new bar for ourselves in terms of the level of quality for those presentations. I mean, just really outstanding. Thank you. They were thoughtful, they were provocative, they were well delivered, and very, very important in terms of that. Secondly, I agree with Jose. I think the afternoon, this conversation format has been just terrific. I thank all of the leaders at the tables. Thank you for stepping up and helping us with that. That would not have been effective without each of you participating. And thank you all for doing that, that you really engaged in a way that we haven't maybe been as much engaged in these conversations before. So each of you, thank you for that. The roundtable members have played an important role in planning, and we'll take this, not only this conversation and create a record of it and disseminate it asynchronously, but it'll also enter our thought processes into how we use this roundtable vehicle more effectively going forward. So we've got we always take some time as a roundtable to sit down after these and try to figure out what we've learned and how we should improve going forward. We'll do that. This will be very stimulating in that regard. It is very important for us to note that we have a very high quality and motivated staff at the IOM that puts this together, and without them, we could not do this. So Alina Bachu, the chief, Darla Thompson, who's been important to this particular workshop, Colin Fink, Amy Geller, and Lila, as well as Tina Reuter, all deserve our thanks for very effective. Our meeting webpage is iom.nationalacademies.org/pop health metrics. And that will, I want to point out to you that one way or another, if you get to that page at the IOM, there will eventually be the video of this. There will eventually be whatever papers that are produced that I hope to stimulate, we hope to stimulate. There will be the resources in terms of the presentations, unless someone tells us we can't do that. Will be on that area, and you can get updated information about our future activities by going back there. So I hope you'll also go to the general roundtable webpage as well for ongoing information about us. So with David Kindig, my partner, in terms of chairing the roundtable, on behalf of the both of us, I want to thank you all, and thank you all for this wonderful day. We're adjourned.